Welcome. Today we are here to do a recap on dyspnea, evidence-based palliative symptom assessment and management. And we're talking about dyspnea, and I'm Amanda. Before we begin, I'd like to do a land acknowledgement. We would like to acknowledge that the land in which we are gathered on today is a traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council comprised of the Chippewas of Beausoleil, Rama, and Georgina Island First Nations, and more recently, the Mississaugas of the Credit River First Nation. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements that peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited to this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous people have the power, strength, competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, culture, and committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. And we are all aware that we are here today as part of the 5-year national initiative to cultivate communities of practice and establish continuous professional development amongst healthcare providers across Canada through the Palliative Care ECHO project. We would like to thank Health Canada for their financial contributions to the project. And now I would like to introduce our fabulous speakers. Today, we are lucky to be joined by Laura Bates and Linda Meeks, both of whom are education specialists or facilitators with our organization, the North Simcoe Muskoka Hospice Palliative Care Network. And they are fabulous speakers. Please enjoy. And ladies, the floor is all yours.
Thank you so much, Amanda. So just a quick reminder that there is a survey. If you could spend a moment or two at the end of this session, filling it out, just giving us feedback on the topic and our facilitation and the series. This will be up again at the end of the presentation in case you don't catch it now.
Hi, everyone. Welcome. I'm Linda. And just to go over the format for today, we're going to be looking at our learning objectives, and then we will replay the actual presentation that we've previously done on dyspnea, and then Laura and I will walk you through a case study. By the end of the session, you should be able to understand the signs, symptoms, assessments, and treatment options for those suffering from dyspnea. Utilize the Cancer Care Ontario guidelines and algorithms for proper assessment and treatment options involving dyspnea, and critically think through a case study from diagnosis to death with someone with a terminal lung condition.
If anybody has trouble hearing or seeing the video, please let us know in the chat.
Today on our discussion on dyspnea. So what is dyspnea? Dyspnea is an uncomfortable sensation or awareness of breathing or the need to breathe. It is subjective in nature, meaning it is what the person describes it is, and the severity can only be determined by the individual. There are some objective measures indicating a respiratory issue. This can also be a warning sign of a health problem needing attention. Cancer Care Ontario defines it as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. The experience derives from interactions among multiple psychological, physiological, social, and environmental factors, and may induce secondary physiological and behavioral responses. I'm just going to play the video here now.
Welcome back, clinical problem solvers. My name is Brian, and I'm a second-year internal medicine resident at the Johns Hopkins Hospital. I am very excited to share our schema for dyspnea with you today. Dyspnea is the subjective sensation of uncomfortable breathing, and it commonly results from problems in the cardiovascular and pulmonary systems. And before we get into this schema, I'd like to make 2 quick points. The first point is that the cause of dyspnea can often be readily identified just with a careful history and physical. For example, how a patient describes their breathing discomfort can often give us insight into the underlying pathophysiology. And the second point is that dyspnea often has multiple etiologies, and it's not uncommon for a patient to have more than one problem contributing to their breathing discomfort. Now this schema characterizes dyspnea into 3 buckets. The first bucket is cardiovascular causes of dyspnea. The second bucket is pulmonary causes of dyspnea. And the third bucket are causes of dyspnea not due to primary problems in the cardiovascular and pulmonary systems. And there's a few subcategories within this bucket. And one caveat I'd like to share with you right off the bat is that dyspnea is an extremely broad topic. And this schema is meant to serve as an introduction to the most common causes without being all-encompassing. So let's go ahead and get started with cardiovascular causes of dyspnea. And within this cardiovascular bucket, we have the myocardium. Examples being heart failure, coronary artery disease or acute coronary syndrome, and valvulopathy, such as aortic stenosis or mitral regurgitation. And this category is typically associated with impaired ability of the ventricle to either fill or eject blood. Next, we have the pericardium, with examples being constrictive pericarditis or tamponade. And in this category, increased pulmonary vascular pressures is typically what leads to dyspnea. And I'd like to share one clinical pearl with you all that Reza had shared with me, and that's that patients within this category can present clinically with heart failure. However, their proBNP may not be elevated because the ventricle itself is unable to stretch within the pericardium. And then the final category within this bucket is electrical. And here we have tachyarrhythmias or bradyarrhythmias, which can both manifest in dyspnea. Our next bucket of causes of dyspnea are pulmonary etiologies. And I find an anatomical approach to be quite useful in this case. And I always like to start with the airways themselves. And examples here being asthma, COPD, or bronchiectasis, which is thickened airways from infection and inflammation. Next, we have the parenchymal category. And this is a broad category. And one example I like to use is interstitial lung diseases. Next, we have the alveoli, where filling processes can often lead to shortness of breath. And those filling processes can occur because of water, pus, or blood. Pulmonary vasculature, such as pulmonary embolism, pulmonary hypertension, vasculitis, and hepatopulmonary syndrome can often lead to dyspnea. And the one pearl I love about hepatopulmonary syndrome is that it can be associated with platysmia. And platysmia is dyspnea when upright that actually improves while supine. And the last category here is the pleura. And examples are pleural effusion or pneumothorax. Our final category, or final bucket rather, are those causes of dyspnea not due to primary problems in the cardiovascular or pulmonary systems. And here we have problems with the chest wall, where reduced chest wall compliance is what leads to dyspnea, and examples being.
So the etiology of dyspnea can be exercise-induced breathlessness or from intense physical activity. It can be caused by environmental issues such as high levels of humidity, freezing temperatures, allergens, smoke, smog, or high altitudes. Obesity is a factor, anxiety, fear, or panic attacks, allergy or anaphylaxis. There's also several acute conditions which can include lung infections, pulmonary emboli, respiratory failure, pulmonary edema, ARDS, collapsed lung, or cardiac arrhythmias. Some chronic conditions can include COPD, asthma, lung cancer, heart failure, or pulmonary fibrosis. Obstruction may also be an issue such as mucus, a foreign body, or a stricture. Some other causes can include generalized weakness, anemia, blood loss, pregnancy, abdominal ascites, or mesothelioma. And Pallium states that the prevalence varies with any underlying condition. COPD can account for 95%, dementia 70%, ALS 50%, stroke 37%, cancer 70%, and congestive heart failure is 61%. So dyspnea can be described in various terms, and the same person can use different terms in the same assessment. It is important to understand that the way the person describes their symptoms are subjective and that they are what they are experiencing. Always be sure to validate their symptoms and experience and provide reassurance. Ensure to properly manage these symptoms to limit suffering, and incidences may increase with the progression of disease. Listed on the slide here are just some of the words that people may use to describe dyspnea. It can be shortness of breath, breathlessness, out of wind, winded, air hunger, can't breathe, can't get air in, or that they are suffocating. The cycle of breathless, this is what happens. Your breathing gets shallower and faster. You may feel that you're not getting as much oxygen from your breaths. Your muscles then begin to tense and you start to feel nervous to do things. The fear of not being able to breathe makes your shortness of breath then worse. So this is just a diagram showing that she's feeling short of breath. Her respirations are then shallow, which increases the tensity in your muscles. She then gets anxious, which increases the worseness, feeling, and shortness of breath, limiting her activities, making her then more anxious. And the cycle repeats itself. So some symptoms, these are objective, indicating a respiratory issue, can include some cyanosis, or the bluish coloring you may notice on extremities. They can experience an onset of confusion, orthopnea, which is breathing through your mouth, decreased air entry with wheezes, crackles, statico, which is the need to take a pause while talking, reduced oxygen levels. There can be dullness noted on percussion, the use of accessory muscles whenever they're breathing. And if you hear an audible stridor, dilated anterior chest wall veins, upper extremity swelling, facial and periorbital swelling, this is an emergency and requires immediate medical attention. Acute can last for a few minutes or hours. If it's chronic, that's lasting days to years with baseline dyspnea levels with an acute exacerbation. Always get the person to describe their symptoms as they are the ones experiencing them. However, also obtain observable symptoms that family and friends notice that the patient may not. I know from past experience, a client may deny being short of breath, but has audible wheezes, labored breathing, and has mild cyanosis in their fingernails. Often family members state their opinion based on what they observe. Many patients experience severe or unpredictable dyspnea crises that, when superimposed on relentless background of dyspnea, often trigger additional fear, panic, and feeling of helplessness and further erosion of the quality of life among patients and their family or caregivers. Some of the consequences of dyspnea can include an isolation when the person does not have the energy or the breath to go out of the home, severe anxiety, mobility issues, emotional and social functioning, the ability to do their own activities of daily living or independent activities of daily living, or ongoing fear that they will suffocate. In regards to an assessment, all palliative patients should be screened for dyspnea at each visit, even if they do not complain of this symptom. Throughout our research on this topic, it was noted several times that assessing dyspnea is poorly done, resulting in underdiagnosis and undertreatment of this distressing symptom. One of the screening tools used for dyspnea or shortness of breath is the ESAS. We review symptom reports with the patient and their caregiver and address any other distressing symptoms that the patient identifies. Assessments will vary based on the symptoms and severity of the attacks. You can then use the ESAS score to determine the severity level on the CCO algorithm as seen on this slide. So it describes here, you have the patient rate their shortness of breath on a scale of 1 to 10, and would they rate it mild, moderate, or severe. So you can see the descriptive words underneath each category. Mild would include the patient can sit or lie quietly. The dyspnea is intermittent or persistent. It worsens with exertion, but resolves at rest. The patient experiences no anxiety or some mild anxiety during their shortness of breath, and the breathing is not observed as labored. Whereas obviously if you increase the moderate, it's usually persistent. The dyspnea can be new or chronic. The shortness of breath worsens if walking or with exertion, but settles partially with rest. They have sentence dyspnea, which they pause while talking every 30 seconds. Their breathing may be mildly labored. You can see cyanosis. There could be the onset of confusion, reduced oxygen saturations, or again, the orthopnea where they're breathing through their mouth. And severe dyspnea is often acute or chronic. The dyspnea can worsen over days or weeks. They can again experience anxiety. They can wake suddenly with shortness of breath. There can be labored breathing when awake and asleep. They have to take more frequent pauses while speaking. Again, you will see the cyanosis, potentially onset of confusion, reduced oxygen saturation, and orthopnea. So we can also complete an OPQRST acronym just for assessing that. We can assess for other risk factors and complete a physical assessment. There's also the Borg scale to help patients assess their shortness of breath using that scale of 1 to 10. It is used to measure a person's perception of their effort and exertion, breathlessness, and fatigue during physical work. So this is just the acronym that we can use for assessment. O is onset. When did your symptom begin? How long did it last? And how often does it occur? P is provoking or palliating. What brings it on? What makes it better? What makes it worse? Q is quality. What does it feel like? Can you describe your shortness of breath? And have you experienced this before? R is region irradiating. Where is it? Does it spread anywhere? S is severity. So use an appropriate severity scale such as the Wong-Baker Faces scale or a numerical scale. What is the intensity of this symptom? Right now, at best, at worst, or on average? How bothered are you by the symptoms? Are there any other symptoms that accompany the symptom? T is treatment. What medications are you currently using and how effective are they? Do you have any side effects from the medications and the treatments that you're currently prescribed? And what medications and treatments have you used in the past and did they work well for you? And if not, why? U is understanding or the impact on clients. So what do you believe is causing the symptom? How is the symptom affecting you or your family? And what does it interfere with, such as sleep, work or school, concentration, etc.? And V are the values. What is the goal of this patient with this symptom? What is their comfort level or comfort goal? Are there any other views or feelings about the symptom that are important to them or their family? Other assessment tools in obtaining the whole picture can include the Palliative Performance Scale or PPS, the Clinical Frailty Scale, the CCO algorithm, and CAM for the delirium caused by hypoxia. To gather the full clinical picture of the person's experience with dyspnea, the clinician requires the client's self-reporting of their symptom in addition to observable symptoms. There is also the oxygen cost diagram not shown, which starts at 0 to 10, and which is the patient typically sleeping, and then increases to 100%, which would show them walking up a hill briskly. It's a simple scale which quantifies the patient's tolerance to exercise and is frequently used in clinical trials. Depending on the patient and their status, this may or not be an appropriate tool, which we don't typically use it here or in the hospital setting. It's important to gather a health history, both general and symptom focused, to include their occupation, those that are around mineral dust such as coal, silica, or asbestos, organic dust such as cotton, woods, or grains, metal and welding fumes, diesel engines, asphalt tar, smoke, chemical gases, and vapors may be at higher risk. Their current diagnoses and the dates that they were diagnosed, any comorbidities, family history, and risk factors including heart disease, cancers, asthma, allergies, reflux, obesity, respiratory infections, and anemia, and the number of exacerbations they've had, and therefore the number of hospitalizations that they have experienced. A comprehensive physical assessment can include the skin temperature. There'll be different temperatures in different locations of the body. Skin coloring, are they pale, are they modeling, or is there cyanosis through that blue color? Positioning, does it worsen or improve their breathing? The mental status, confusion, delirium, anxiety. A respiratory assessment, looking for edema, if there's periorbital, peripheral, abdominal ascites, and then psychological issues. Is there any pre-existing anxiety or panic disorders? Also look to see if they're tense or grimacing, if they're gripping the chair, or if they have their hands across their chest, and then check their nutritional and hydration status. So the respiratory assessment, look for the rate, the rhythm, the pattern, cosmos, chain stokes, or hyperventilations. Upon percussion, or is it dull or tympanic? The auscultation, the sounds, listen to them and where is the location, do both inspiration and expiration. Accessory muscle use, positioning when they're breathing, are they in the tripod positioning? Breathing on exertion, the skin color and temperature, their oxygen saturations with both rest and activity. You don't necessarily have to do this at the patient's end of life. And then their oxygen use. So you want to know the rate, the device that they're using, and the changes to flow with activity. Some people will go from like a 2 to a 5 if they're up and walking. Some diagnostic tests can include the spirometry or pulse oximetry, pulmonary function tests, doing a chest x-ray or CT of the chest, MRI, ECG, exercise stress tests, echocardiogram, ventilation or perfusion scans. Some lab work that may be done would be the CBC, thyroid, cardiac, extended lights, or ABG. Some more invasive diagnostics can include a bronchoscopy, a thoracentesis, or biopsy. They can also do gastrointestinal testing or potentially psychiatric evaluation if needed. And Julie will take it over for treatment options.
Thanks, Bethany. We want to determine the cause of the dyspnea, whether it's treatable or not, and what are the goals of care for the person. So with goals of care, they're going to vary and change at different points along their trajectory of their disease. Is also dependent on available interventions that can be offered. Informed consent will be needed to make those appropriate decisions regarding their own medical care. And if they cannot, the power of attorney for healthcare decisions. Some challenges that we were able to discover in managing breathlessness include patients not expressing their distress, patients' refusal to use opiates related to misconceptions about narcotics, doctors' reluctance to prescribing opiates related to the opiate crisis issues, knowledge deficit about the use of opiates in lung conditions that are not malignant like COPD. Some of the prescribers' attitudes and beliefs regarding the use of opiates and the lack of experience, as well as delayed access to palliative care and specialty consults, can also pose a challenge. Some frustrations noted by healthcare professionals, patients, and families on the suboptimal control and management of the symptom. And one article revealed that doctors were not comfortable prescribing and managing opiates outside of the hospital environment. This chart here just demonstrates some potentially treatable causes and what those treatment options may include. For COPD, inhaled bronchodilators, inhaled or systemic cortisol, large airway obstruction depending on the cause. Sometimes if it's tumor related, you can do radiation. Sometimes steroids will reduce edema. They may need stenting, and it does say nebulized epinephrine, and I have not seen that in decades. Pneumonia, obviously anticoagulants for pulmonary emboli. If there's some issues with the cardiovascular systems, angina, atrial fib, congestive heart failure, their typical treatment interventions may help with dyspnea. And a palliative emergency, superior vena cava obstruction is the medical emergency, and radiation, stenting, and steroids are needed. If they're anemic, blood cell transfusions will help. And if they have severe ascites, then drain if possible and insert an indwelling catheter if it's going to be an ongoing problem. Pharmacological interventions can include several medications. So first primary is opiates. We want to start low and go slow. Sometimes offering oxygen may help with the comfort of the dyspnea, but if they're not hypoxic, it may not help too much. Back to opiates. Morphine is the #1 choice. And like I said, you want to start really low so we don't cause respiratory depression. Hopefully at this point, they're still on oral medications. You can do 2.5 to 5 every 4 hours regularly with a 2.5 Q1H PRM bolus for breakthrough dyspnea. And obviously, if they can't tolerate the oral route, then sub-Q is the next best thing. And you're going to half that dose from the oral to change it to sub-Q. You want to assess your patients being opiate naive, so they've never really had much use of opiates. You want to start low again at 2.5 to 5 of morphine and 2.5, half of that dose for the breakthrough, and then change it to sub-Q if they can't tolerate it. Frequent monitoring of the effectiveness of the opiates is really important. If the breathlessness is extreme, we may need to escalate fairly quickly, and this would be best managed in a hospital or hospice, some type of nursing facility where they can be monitored properly. And then the doses will have to be adjusted based on their response to the opiates. If the opiates are not enough, we could consider adding Ativan for the anxiety piece of it, as well as Nozanan and other psychoactive medications. So the role of oxygen. If the patient is hypoxic, then the role is definitely beneficial. For non-hypoxic patients, it's kind of unclear, but it may provide that comfort and ease of breathlessness and the anxiety, and it may offer some assistance. There's various delivery methods of the oxygen. It can be supplemental O2, pure liquid oxygen, high flow via nasal cannulas, oxymask, non-rebreather mask flow. And you also want to consider non-invasive, which I just spoke about, versus invasive, which requires intubation. Some patients may do a trial of mechanical ventilation with parameters on extubation. When the patient is close to death, at this point they're unresponsive. There's really no reason to continue oxygen, as hypoxia and the altered breathing patterns such as Cheyne-Stokes and Kussmaul's are normal for this stage. This is definitely not a time to start oxygen therapy. And even if we try to discontinue it because they're restless, they're pulling the cannula out of the nose, sometimes explaining this to families can be difficult. Some other treatment options based on the cause may include a chest tube if there's a pneumothorax, chemotherapy, radiation therapy if there's a cancer, tumor, antibiotics for any infectious pathogens, anticoagulants for blood clots, surgery or resections of part of the lung, draining of fluid, and then BiPAP, CPAP, and mechanical ventilations. All proposed interventions that are offered by the physician needs to be compared to the person's goals of care, and informed consent is required. Some non-pharmacological interventions, which to me is just as important as the medications, is providing that oxygen if beneficial, providing ambient airflow on the face, putting a fan next to them with the air directly blowing on their face, providing the patient with symptom management techniques, supporting the management of breathing techniques, relaxation, and distraction, just to name a few, providing realistic goal settings, offer suggestions for positioning that maximizes air entry, refer to community support such as pulmonary rehab clinics, respiratory therapists, occupational therapists, and physiotherapists. Consider a referral to spiritual care and supportive counseling. Other things that should be done is the advanced care planning, goal setting, resuscitation status, health teaching to client and their families, development of coping mechanisms, early identification to prevent increasing severity and hospitalizations, tracking of exacerbations and hospitalizations through a respiratory journal. And they can track their day-to-day breathing status as well as any extra medications that needed. Some breathing exercise techniques, abdominal breathing when you're up and being active during stair climbing, standing up, or walking uphill. These exercises are done fairly regularly, and they can help you recover from feeling breathless after an activity. So basically what you want to do is relax your shoulders, place one hand on your belly, just below your chest. You're going to count 1, 2, 3, 4. As you take a breath in, feel your abdomen rise slowly. And on 4, you're going to breathe out slowly with pursed lips, like you're whistling or blowing out a candle. And then you're going to count 5, 6. You're going to repeat this 3 to 4 times, practicing 3 times a day and before and after doing any activities that causes breathlessness. Recovery breathing is anytime you feel very breathless or panicky. Step 1 is to use the positions that we're going to show on in a couple of pages here. Drop your chin, breathe in and out while focusing on your breath. Purse your lips. Little by little, you're going to blow out for longer periods. Once your breathing slows down, you're going to sit up straight and do 2 or 3 more abdominal breaths. Rest for a few minutes before starting your activities again. And you can do the recovery breathing while sitting, standing, or lying down. This diagram here just shows the active breathing cycles that we do, which we just kind of described. It talks about the pursed lip breathing and for how long, how many deep breaths you should be doing. And it just keeps going until the person feels more relaxed with their breathing. So this diagram here just shows a couple of the positions that someone can do if they're feeling quite short of breath. If they need to lie down, obviously we're going to put them kind of like in the recovery position, supporting their arms and legs with pillows, allowing the chest to expand with a thick pillow between their arms. While sitting in a chair, leaning forward, kind of in a tripod position, resting the forearms on the thighs. If only you have a wall, you can lean up against the back of the wall, legs wide stance, and just relax. If you have a railing or a countertop or a table, you can certainly lean across with a wide stance and just allow gravity to help open up your chest. Some lifestyle changes to improve dyspnea and prevent exacerbations. Weight loss, increasing physical endurance. So some programs that are dyspnea safe are the VON SMART program or Victoria Order of Nurses, seniors maintaining active roles together, pulmonary rehab, chair exercises, or progressive walking programs. Some dietary changes include small, more frequent meals, taking smaller bites. You're able to breathe in between those bites. Some energy conservation techniques, so sitting to get dressed and putting your footwear on, resting between activities, keeping your items close by so you don't have to get up as many times, having some help with activities between bathing and housekeeping and running errands. Quit smoking will certainly help, even if you've been a long time smoker. Taking your medications as prescribed. Learning to ask for help is probably one of the hardest things to do. Using mobility aids, that walker, cane, wheelchair, bathroom aids, having the head of the bed elevated to help with breathing. And there's also adaptable cleaning aids. You can try and remain as independent as possible without exerting too much energy. Relaxation and meditation exercises, other environmental changes, so the use of air filter, air conditioning, fans, trying to keep a smoke-free home, staying inside with weather extremes, really cold or really hot and humid, try to keep the dust down, and have yourself and your visitors try to avoid perfumes and heavy fragrances. Some of the signs of intractable symptoms of breathlessness, it is very complex and it's usually multifactorial. It's usually associated with anxiety, and also terminal secretions may increase the feeling of breathlessness. 15 to 70% of clients experience breathlessness at the end of life. It's the most prominent symptom in end-stage lung and heart disease. It's a devastating system of advanced cancer, causing distress and isolation for patients. Just a few of the treatment options for intractable breathlessness include revisiting their goals of care, making sure what they want for end of life is still what they like. Higher opiate dosings at end of life. There's no ceiling limit on opiates. You can go high. Palliative sedation is an option, as well as medical assistance in dying are made. Although there are therapeutic advances in the clinical management of dyspnea, they are limited and it often remains difficult to treat successfully. Palliative doctors and other specialists will be required to assess and manage terminal dyspnea, and also the use of the multi-teams, palliative nurses, spiritual care, respiratory therapists, home care managers. If we are going to do palliative sedation, often midazolam, Nozanan, and or Ativan, or a combination of those three, is often used. Dyspnea at the end of life, we need to make sure we have the correct resuscitation status for that patient, making sure that the advanced care planning is completed, goals of care are revisited at this time, quality of care and versus quantity, some legacy work, and end-of-life wishes. Some common things with medications at the end of life, often sub-Q route is best. They're too short of breath to be able to even take sips of water to swallow all those pills. Opiates are the primary medication for dyspnea. Still need to reassess those symptoms frequently and increase doses as necessary to maintain comfort. And like I said, dose escalation can get quite high. Adding a benzodiazepine like Ativan if the opiate is not effective on its own, or if anxiety is definitely a component. Terminal secretions may occur and cause difficulty swallowing and distress. Often here in Ontario, we use scopolamine and glycoprolate to try to help manage this symptom. Dyspnea-related agitation can be managed, hopefully, by the use of an antipsychotic like Nozanan, and then add Ativan if it hasn't already been done at this point. Opiates, when used appropriately at the end of life, will not alter respiratory status because that's going to happen naturally, or hasten death. And the most common opiates that we use for end of life is hydromorphone and morphine subcutaneous.
So now we're going to go through a case study. For the most part, if you're comfortable, please unmute and just speak up or put your hand up and then unmute yourself. But if you're not comfortable with doing that with the size of group that we've got, you're welcome to put your answers and thoughts and questions into the chat. Let's get into our case study, Linda.
Okay, we'd just like to say thanks again to Carleen Battaglia, who's a partner a respiratory therapist. I think she might even be here with us today for help with information about case study. So this is Anne. We'll give you some background information. Anne is a 67-year-old female with a diagnosis of pulmonary fibrosis for the last 2 years. She was a hairdresser for the last 35 years, but is now on long-term disability. She has ongoing symptoms, which include shortness of breath on exertion since before her diagnosis, fatigue, and an occasional dry cough. She's single with 2 adult children and 1 grandchild. She lives in a 2-story home by herself, and she has a dog who is quite active. It's probably a lab, right, Laura?
Probably. I hope everybody is familiar with pulmonary fibrosis. If not, please put it in the chat. We can talk about it after.
So at a physician visit, the visit today is due to increased shortness of breath on exertion and starting with some mild shortness of breath at rest. Her current medications include Ofev, Pantaloc for GERD, ASA 81 milligrams for DVT prophylaxis due to decreased mobility, and the MD has ordered a CT of the chest and a chest X-ray to rule out pneumonia or other infections and to assess disease progression. A referral was made to the North Simcoe Muskoka Hospice Palliative Care nurse for a nurse consultant assessment to be done. What assessments and discussions should be done on the first visit? So if you'd like to unmute or put that in the chat. What assessments are done on the first visit to this patient? I'm not seeing anything. Are you, Laura?
Not yet. Oh, there's
Okay.
there's a couple popping up.
Okay.
So-
Yeah. Physical assessment, which includes ESAS and OPQRSTUV. Absolutely. What her goals of care are related to dyspnea management, for sure.
Good. That's a vital conversation, especially on that first visit, so that you can understand where your patient is aiming to be.
What else? What supports does she have at home? You might want to use, what's this one? What is her understanding of her disease at this time? That's a fantastic discussion to have some health teaching done.
Mhm.
Maybe in her physical assessment, we might want to use other tools besides ESAS, OPQRSTUV. What would maybe some of those be that we mentioned? So the frailty scale, clinical frailty scale, palliative performance scale, and we would want to be using our Cancer Care Ontario algorithm. Anything else you want to add, Laura?
I don't think so, Linda. I think that's a pretty busy first visit.
Okay. Let's see what's on the next slide.
What about assessing how it's affecting her daily living, affecting her managing her ADLs, her IADLs, and what her home setup is all about and how that plays into her daily routine?
That's
Excellent.
right, Lisa. That's our fantastic health at home coordinator. Thank you for sure. Those assessments of those types of things, of activities of daily living.
Mm-hmm.
Thank you, Lisa. So the hospice palliative nurse consultant visit, the assessment is to be done in her home a week after the MD visit. Advanced care planning is discussed, and it's decided or known that she has not assigned a power of attorney for healthcare decisions as of yet. She's not aware of her prognosis. No end-of-life discussion has taken place. With the use of the assessment tools, PPS is 50%. ESAS for dyspnea, it's 4 to 5. Anxiety is 3 out of 10. And the clinical frailty scale is 5, which is mild. OPQRS-TUV is done. A chest assessment, which shows inspiratory crackles, productive cough. S1, S2 heart sounds are normal. On the skin assessment, it's noted that she has clubbing of her fingernails and no cyanosis is seen in the nail beds. Staccato positive when walking more than 2 minutes. And oxygen saturation at rest is 92% on room air after a 2-minute walk and 88% on room air.
Next slide.
Yes, please.
Okay.
Questions. According to the Cancer Care Ontario algorithm and her ESAS score of 4, where is she on the severity scale?
Oh, that was quick. Somebody popped a
yay,
moderate in
moderate.
there right
Yeah.
away.
And with the recorded oxygen saturation, should she start to use O2? So this, can you just go back the slide?
Yep.
Laura, it was, I remember, 88% on room air after walking and 92% on room air after a 2-minute walk. So should she have a referral for some oxygen? What do you think? Possibly.
Mhm.
Any other answers to that? I think I would look into that referral possibly to see an RT or have a referral for oxygen just as needed.
Mm-hmm. She definitely wouldn't have to use it all the time.
Yeah.
At least not to start.
And what should our next steps be with Anne and what referrals would you make? Oh, someone said if it's something she pushes for, if not, I would wait as there is oh, that's true, limited
Yeah.
time for coverage. I believe it's 3 months. And then you have to pay for it. Another good thought.
Yeah. Important to remember in the home situation.
So what should our next steps be with Anne and what referrals would we make? Oh, someone said in Alberta, she would not qualify for supplemental oxygen at 88%. She would have to pay for it herself.
Interesting.
Thanks for that little tidbit.
Mm-hmm. See, the little things you don't necessarily think about from province to province. But in Saskatchewan, she would be covered.
So what would our next steps be?
Kathy says RT, social worker, maybe about the anxiety or spiritual care if she's inclined.
Those would be great referrals.
Mm-hmm.
And would you suggest any medications for the MD? Oh, we'll go back a little bit. Is she on home care? Referral to home care? And then the suggested medications would be low dose opioids.
Yep. I would even consider something for the anxiety if it's determined that that is a a big part of her cycle.
Maybe some Ativan.
Hmm. Yeah, Louise was thinking sort of that cleaning and taking care of her pet. She might need some sort of practical help in doing some of those things. It's good to think about too, especially if that's available in your area and covered by government funding or other funding.
Yes, not so much in Ontario. And
Yeah.
someone to walk the dog.
Yep.
Okay, Laura, next slide, please.
There you go.
The palliative nurse consultant reassesses Anne and finds the following data. PPS is now 40%. ESAS for dyspnea is now 6 at rest and 7 with activity. ESAS for anxiety is now a new symptom and the score is 5 out of 10. And oxygen saturation at rest is now 89%, and after a 1-minute walk, it reduces to 86%. What should the palliative nurse recommend for interventions, both pharmacological and non-pharmacological strategies for symptom control? Okay, let's talk about non-pharmacological first. What things could we do for her to help control her symptoms?
You know me, Linda. I'm always about the fan or the open window breeze.
Fan, open window breeze, breathing exercises.
Yep. Making sure she knows about those positions that can help ease her shortness of breath. Oh, somebody said OT referral, maybe a hospital bed if her bed can't be set up to help her be more elevated. Energy conservation techniques, those are huge. People don't always realize that it's okay to do things in steps and take breaks to catch your breath, that you're not causing dyspnea that is difficult to recover from at the end.
Yeah.
You know?
Someone said open curtains,
Yep.
mindfulness, and scent control. So
Yeah.
those are all great. And now what about what pharmacological interventions? We're now in the 6 to 7 range on ESAS. So if we're not sure, where can we actually go to look? My favorite tool of all time. Titrates opioids, perhaps some midazolam, palliative symptom guidelines,
Yep.
and the Cancer Care Ontario algorithm
Yep.
for dyspnea has it all laid out for us.
Yep. Changing her opioids to around the clock instead of PRN, or if she's been taking them around the clock, then maybe adding a long acting in. Yep, the algorithm lays all the steps out. Your palliative pocketbook, whatever your provincial guidelines are for symptom assessment and management, if you have one other than the Ontario one that you can use. Oh, Louise says, if the person's on a pain med other than morphine, do you adjust the opioid if dyspnea is a concern? It would depend on what they're on and why.
And what home care services would Anne benefit from at this time? We did mention a couple of things. So obviously in Ontario, hopefully she has a care coordinator from Health at Home, and they would help to put what she needs in place. But so what home care services would that include? Nursing, PSW.
Equipment, care aids or PSWs, yep.
Yeah, so they might also have referrals for respiratory therapy or any other kind of referrals that are needed that can be done.
Mm-hmm. Some areas offer housekeeping and those sort of more practical things. Oh, somebody mentioned the hospice visitor.
Oh, yeah.
Always a good resource at this point. Always. If they're not there already, time to bring them in.
And would you discuss end-of-life care at this point in the trajectory?
I see a capitalized yes. And somebody else mentioned yes, because we need to know what their wishes are for end of life care. Whether they need to be, referred to a hospice or a inpatient unit or something like that. We need to know that ahead of time, possibly.
Yeah.
Yeah. And you know me, Linda, I'm always about let's talk about the inevitable before it becomes a crisis. If it hasn't been discussed by now, it needs to be discussed
It
now.
should be, yes.
Mhm.
Are you on the next slides, Laura? I don't know what number we're at, so.
No, it's me.
Okay.
From that, this is the new referrals and the new orders that have been started. She's given hydromorph by mouth to be taken every 4 hours as needed, and she can also take it every hour as needed if it's worsened. She's got an O2 referral done, and the RT starts her oxygen at 2 liters per minute. And she does have a PRN order of Ativan for anxiety during a spell of dyspnea if required. So 6 months later, her condition is significantly deteriorated and she cannot be cared for at home alone. Her oxygen needs have increased and she's now at 5 liters per minute. She's mostly bedbound and only getting up to the commode at the bedside, and even this is a challenge for her to do independently safely. She's no longer able to get to the kitchen to make any meals, and she expresses to her visiting nurse that she no longer wants to live like this and does not want to suffocate at the end. So despite any interventions and any extra people that we've brought into this point, she feels like she is suffering. How would you explore this with Anne? If you were the visiting nurse and Anne said that she did not want to suffocate at the end and did not want to continue like this, what kind of options would be available to her? And how would you explain it so she can understand? I see a sedation, palliative sedation, possibly made. Yep, definitely. This is an excellent trigger point for another goals of care discussion and determining whether she is okay with excellent symptom control, but possibly being sedated or sleepy and unable to converse with her family or do things that she wants to do, versus being a little more awake or a little more aware and possibly still having an uncomfortable level of dyspnea. It's also important to know what level of dyspnea is acceptable to her. So for you and I, a 4 out of 10 might be the highest we want it to be. Whereas she might be okay with a 5 or a 6, but nothing higher than that. That's right. Somebody put in the chat, the understanding of what's happening and what's acceptable to her and what's not. So really exploring what she wants this to look like. If she decided to pursue sedation or MAID, then that would be on the nurse to go off to her primary physician and ensure that the primary physician is also having those discussions with her, or her nurse practitioner if that's her primary care provider. So what else could we do before we get to sedation or MAID to try and maximize symptom control at this point? Is there anything we could do? I see somebody suggesting Sept, which I'm not personally familiar with. If you could pop a bit more about that in the chat, Christina, or even unmute yourself if you want, just to let us know.
Hi there, it's just that much stronger than fentanyl.
Okay, perfect. We're just escalating the opioids.
For sure, intranasal or sublingual.
Awesome. Don't need to worry about swallowing it or getting an injection.
Mhm.
Perfect. Yeah, we'd be maximizing all the available medications. Puffers if possible. If she's still able to take them effectively, for sure. If she's got an aero chamber, definitely. Yeah, making sure we've optimized those non-pharmacological interventions also. Perfect. So her condition continues to progress and worsen. She has significant shortness of breath even at rest. She's not able to eat much, mostly down to fluids at this point, and she doesn't feel she's receiving optimal symptom control. She decides to be admitted to the local residential hospice, and Anne feels she is suffering, and agrees that she would like to pursue palliative sedation because she would like to die with dignity, with as much peace as possible, and to be as symptom-free as possible. In your area, would palliative sedation be an appropriate thing at this point? It doesn't say what her PPS is. That might be a qualifying factor. But in your area of practice or your province, would this be an appropriate time for palliative sedation? Let's assume her PPS is probably down to a 20%, given she's down to minimal liquids, bedbound. You see one, yes. Yep. Yep. If that's what she wants, then yes, this would be an appropriate time to begin it. Yeah.
Lots of yes, yes.
Yeah. At 20%, you know, we're not doing something that is going to hasten the process because she is very evidently at end of life. What kind of health teaching needs to be done when palliative sedation is being started? Now, what you would be completing depends on your discipline, but in your scope of practice, what kind of teaching needs to be done? As a nurse, we always have to discuss the use of palliative sedation for symptom management, that we're not changing the timeline and the trajectory. What do families need to be told, especially? You guys want to pop that in the chat. I'm going to keep moving on just so that we're not too far over time. We need to ensure that we discuss all the possibilities of how this is going to look. Not waking, not eating, not drinking, and that the goal is comfort. And if comfort means, yeah, Charlene, ask if they wake up. If comfort means being sedated, then that's what we're going for. Monitoring and initiation will depend on your scope of practice and your sector of care. But yeah, you guys have got all of those in there. That's good. She started on a midazolam pump and receives excellent nursing care and dies 2 days after the initiation of the palliative sedation, peacefully as she wished, with no signs of distress, and daughters were content with the level of care that she received. So just a thought for you to take away is, if she did not do terminal or palliative sedation, have a peek at the algorithm and see what other options would be available for breathlessness at end of life when sedation is not the goal. Again, thank you so much for joining us today. Thank you to Linda for co-hosting with me today, and thank you to Amanda for hosting. And look for an email with the recording and all of these links and a PDF of the slides in the next few days.
And this will be processed hopefully today, if not tomorrow. And thank you so much, Laura and Linda. That was fantastic. And thank you everyone for being engaged in the chat. This was, I think, one of our most engaging conversations, and a lot of great information was shared today. Don't forget to sign up for our next session. All the information is on our website, the nsmhpcn.ca/echo, where we will be talking about palliative care emergencies and do you know what to do? That is in October. Check that out. Sign up if you haven't. Thank you very much. And we will include all of the resources that were mentioned with this when Laura sends out the follow-up email.
Thanks much, everybody. Have a great day.